The care of HER2-positive metastatic breast cancer improved tremendously over the last few years with the introduction of new agents like pertuzumab and trastuzumab emtansine. It has really improved outcomes for these patients. It is estimated that a patient diagnosed today with metastatic HER2-positive breast cancer would have an average survival of about 5 years, which is really a dramatic improvement over just a decade ago. And that's been largely thanks to the introduction of anti-HER2 therapies, both alone and combination with other modalities like chemotherapy and hormonal therapy. HER2-positive breast cancer in the neoadjuvant setting has also been doing well. The introduction of anti-HER2 agents has really dramatically improved responses in the neoadjuvant setting, and dual anti-HER2 even increased that further. The question became, once we introduced those new agents, is who benefits from those patients, from those agents the most, and who doesn't? Because a lot of those neoadjuvant wins did not translate into equal adjuvant outcome improvements. And that's probably because we are giving those patients those treatments without prior selection based on molecular factors. And of course, that's not easy to do, but I would have to say that that's the next thing for neoadjuvant treatment, is to really be able to identify, based on the biology of the disease and the characteristics of the patients, those people who need to be treated with more treatment, say be given more therapy, and those patients who may be spared the duration of the therapy. They may not need a new anti-HER2 agent, or they may not need as much chemotherapy, and actually some may not need chemotherapy at all. And so I think the neoadjuvant platform in the HER2-positive setting is going to be a very powerful platform to test those hypotheses of profiling tumors and then tailoring treatments according to the molecular makeup of the tumor. NSABP B-52 was a very important trial. It was designed to validate the preclinical findings and the clinical findings that inhibition of the estrogen receptor might be important, along with HER2, in patients whose tumors express both ER and HER2. The trial gave those patients estrogen deprivation added to chemotherapy and dual anti-HER2 inhibition or not. And despite showing a small advantage or small increase in the pathologic complete response, that was less than what was anticipated based on the statistical assumption. But that treatment was really going to be part of the treatment of the patient's management plan anyway, and also did not add to toxicity. Now, a lot of work that we have been doing in NSABP B-52 was trying to understand the reasons that patients respond or not respond. Essentially, we're doing a lot of molecular profiling of tumor biopsies that were obtained at baseline, during treatment, and the residual disease that was found at the time of surgery to try and understand which patients benefit from those strategies and which are not. But you know, the concept of inhibiting ER and HER2 has panned out in the metastatic setting. The PERTAIN trial showed that dual anti-HER2 inhibition with anti-estrogen therapy is an effective strategy, even when applied without chemotherapy. In the neoadjuvant setting, I think the same will be true. It's a matter of selecting the right patients for it. So the next step is really to try and understand which patients benefit from those treatments and which don't, and then also a look again at a rational and molecularly guided way to de-escalate treatment. Maybe some of those patients don't need the chemotherapy component and could receive anti-HER2 treatment plus hormonal therapy or estrogen deprivation as a strategy. We have explored that in multiple trials that showed really that those treatments are efficacious, and I think larger validation trials are needed so that this becomes part of the routine management of those patients. So residual disease after neoadjuvant chemotherapy could kind of be looked at one of two different ways. There are some patients or some subgroups of breast cancer, say triple negative breast cancer and ER negative HER2 positive breast cancer, where the presence of residual disease may be a sign that the treatment did not work as well on those tumors, and there's resistance and potential for higher risk of recurrence. This is most especially relevant if the patient has received all of the optimal treatment up front, and so we're looking at the end result of that. And for those patients, I think that there are several investigational or several trials are trying to explore that. There is the Catherine trial that's looking at adjuvant trastuzumab and tansine versus trastuzumab to try and address that. There are trials that are looking at adding immune checkpoint inhibitors for those patients. So the answer is, if the tumor is ER negative, then residual disease after optimal neoadjuvant therapy may be a sign of a higher risk. For tumors that are ER positive, HER2 positive, or just ER positive, residual disease after optimal neoadjuvant treatment may not carry the same weight in the prognosis of those patients. And the reason for that is simple. First of all, those are biologically different. Several molecular profiling studies have shown us, and some of it is data we're presenting at this meeting, that there's a lot of heterogeneity within a disease group itself. Even within HER2 positive disease, you will find all the subtypes of breast cancer, not only the HER2 enriched. So you may be looking at a disease type like a luminal type of breast cancer, the ER positive, that's not very sensitive to chemotherapy, but it doesn't mean that that's going to be a high-risk disease. The second element is that those patients receive after that years of endocrine therapy, which would modify that risk. So you're not looking at the end result that you're looking at the time of surgery is not the end of the patient's treatment. They are going to get more treatment that may modify that disease, and studies have shown that maybe a lot of those patients may do well. There are going to be some of them that are high risk, and again, we go back to interrogating that residual disease and seeing what is the molecular picture, and is it really residual disease that's highly resistant and aggressive, or is it just a low-grade disease that's just not shrinking very rapidly? And I think that would help us better address the needs of those patients, because we could design the clinical trials for those patients who are at highest risk for recurrence and hopefully change their outcomes more efficiently and in a more compelling way. I think there isn't one study or one session that I could point at that I would say this would be the highlight of the meeting. I think now in its 40th year, the San Antonio Breast Cancer Symposium has shown that there is really the power of incremental improvements to patient outcomes. We have seen multiple meta-analyses showing that treatment strategies that we have designed, or the community in general worked on 10, 20, 30 years ago, are continuing to make a difference for patient outcomes. Even control arms on clinical trials are showing us that the patients are doing better than expected, because we're delivering standard of care in a better way, we're giving them better supportive care. We are understanding more about the biology of the disease and targeting treatment to the specific biology of the cancer. There are a lot of promising new agents. Today we heard about a new agent that has a promising activity in triple negative breast cancer. It's an antibody drug conjugate. We heard news about some promising early results for immune checkpoint inhibitors in a subset of HER2 positive breast cancer. And we also heard that extending anti-HER2 therapy to tumors that express low levels of HER2 is not effective, and thus kind of keeping HER2 treatments for the patients who are overexpressors or amplified in that. So we are trying to kind of limit unnecessary treatment for those who don't need it, but expand it for those who do. And I think this is what you're going to continue to see. Incremental improvement in various areas, and then people come together and move care forward, a couple percentage points every time, but over a decade or less, you will see a remarkable difference. And so I would say it's really the power of collective knowledge and incremental improvements in outcomes for patients.